Whenever we talk about mental health these days, there's a big question. Does it work? Okay, how many of you have had frustration referring to mental health and saying, well, it got lost into the black hole and I don't know what's going on? Have any of you referred to mental health within the last few years? You had an opportunity to do that? I see somebody nodding there.
Through mobile crisis?
Through mobile crisis. Okay, what was that experience like for you?
It was through law enforcement.
Through law enforcement, okay.
I retired from the PD. We did a lot of work with.
Okay, wood emergency services, okay, especially of Woodburn, I'm sure. Okay, okay. Well, that is not an unusual entry point for many of our clients, and for people that probably through CASA will either have had some connection with mental health or might have some future connection with mental health. When I look at mental health services as a program manager, as an evaluator, as a clinician, supervisor, and trainer, I'm going to be looking for three things to happen. First of all, I need to have treatment be effective. Okay, that is really the most important thing. If it doesn't work, why are we doing this? Okay, so the question of effectiveness is number one in terms of looking at treatment, where we're going, why we're doing it, and how we're going to do it. The second issue, and particularly in a community mental health system, all right, although with managed care and HMOs this also comes to bear, is the question of efficiency, all right. Are we doing it in the most timely manner? Are we using the quickest resources to bring about the quickest results? Are we using cost-efficient mechanisms to doing treatment? And then the last issue that we take a look at, the criterion, I call it the C test, the SEE test, is sufficiency. Are we doing what's sufficient to take care of the issues that are being presented to us? Now, sufficiency is a very interesting question because less often is not the way to go, all right? You'll hear a lot about brief therapy, short-term therapy. I'd like this group to kind of eliminate those ideas and think about focused therapy, all right? That is a very difficult concept for people to wrap around a bit because we think of therapy as people coming in and just talking to a therapist and going on, and you know, the pictures of people laying on couches. There's an awful program going on. I don't know if anybody's seen that program, Treatment. Oh dear, okay. That is, I mean, just, it really gives me a pain just to kind of watch that because it promotes the idea of this kind of undifferentiated, you know, let's just sit here and just talk about whatever goes on during the week or in our heads and so forth. And honest, folks, that is not what sufficient, effective, and efficient treatment is all about, all right? When we look at therapy and when we look at general mental health services, we're looking to produce four things. Anybody guess what those four things might be? Okay, it's kind of hard. First of all, stabilization. Okay, that is really, you can't go anywhere if the client, the family, the situation is not stable. Once we've achieved stabilization, we need to think about keeping it. So we work on the second goal, which is relapse prevention. Okay. Third goal, and in a lot of situations, particularly in the private sector, folks forget this one, which is community maintenance and integration. Okay. And finally, and the one that we hope for, but sometimes we can't achieve, is what we call adaptive behavior change. Okay. When we talk about stabilization, we're really talking about bringing the individual, be it symptomatically, someone who is depressed, psychotic, having panic attacks, to a point where they can function again. So the gentleman who's worked with the police department and emergency, I'm sure you've met with people who are totally deregulated in one way or another, either psychotic, domestic abuse, things of that sort. Okay, this is where we put our stabilization efforts into place. And may I have your name?
John.
John, all right. As John mentioned, we're very fortunate in this area to have what we call the mobile crisis unit, in which clinicians, psychiatrists, staff members will actually be called out, usually by the police. There are some other ways that can be done, to go into the situation and basically to stabilize the situation, all right? However, when we're talking about stabilization, we can also talk about someone coming in to an individual therapist's office. We can also talk about somebody going into a regular outpatient intake process, all right? The whole idea there is to get the person to a place where they are comfortable enough and intact enough to be able to do something else besides live in this chronic or ongoing crisis state, okay? When we get to that, we then start to think about, let's keep this going. How do we prevent a relapse, all right? Oftentimes when we've stabilized somebody, we've medicated them, all right? We've brought in families, we've brought in significant others and so forth, and we try to basically settle that particular situation down, get the person non-psychotic. Sometimes we have to hospitalize, hopefully not. There are other things that can be done there. But the idea is once that's happened, something needs to go on to keep it going, all right? Because we just don't have that magic of laying on hands and, seeing a therapist doesn't do it. Many, many other things have to happen. So in stabilization, we often bring into effect medication services. Have any of you dealt with anybody who's been medicated? Okay. What's that experience been like?
In the beginning, because of the cultural differences,
Yes.
she wasn't receptive to taking medications, but now she's been on it for about almost a year.
Almost a year.
Now she sees how calm she's been.
Right. Do you have any idea how many times the medications had to be changed?
3.
3 times. Okay. That's not bad, 3 times. Okay. Did she have side effects?
I know in the first instance there was side effects.
Right.
But I'm not sure.
Okay. Unlike, let's say, if we came down with strep, if we came down with, some sort of infection of some sort, psychotropic medications are basically like making a wedding dress, all right? I'm looking at the ladies around here and the gentlemen. If you're married, you know what this is like. You can pick something off the rack, but you have to tailor make it to that individual's brain, all right? Your brain and your brain may be totally different, all right? You may, let's say if we're dealing with a depression, you may be low on dopamine. You, on the other hand, may be low on norepinephrine. And this lady here may be low on serotonin. There's a whole slew of medications just around the issue of depression. And oftentimes it is a question of trial and error. So just in the stabilization effort, all right, we may go several weeks before we hit the right medication for an individual. So people come into emergency, they say, okay, we got them over there, they're going to put them on meds, and what happens, it's still a no-go. So the question of medication monitoring, evaluation, follow-up is extremely, extremely important. Side effects, are these transient side effects? Will they go away in 2 or 3 weeks? Or are they serious side effects that the medication has to be eliminated immediately? Okay, so just on the issue of medications, stabilization can be a problem, all right? Along with, let's say, medication, crisis intervention sessions, family, the individual, couples, and I want to give you a clue on this. Crisis intervention sessions must be problem-solving sessions, all right? It can't simply be repeating history over and over and over again. You go to one therapist, to another department. Crisis intervention sessions must come up with identifying workable problems. So if you have a couple who's in the middle of a domestic dispute, all right, it really comes down to a question of negotiation and mediation. Okay, now again, this is not our general idea of therapy. When we're talking about actually sitting down and mediating between people, negotiating, coming up with agreements on what one person will do, what person will do, not do. Okay, again, this is the kind of thing that goes into play when we're talking about stabilization efforts. Bringing in additional family members, you know, saying this child, and this is something that I know CASA is very well familiar with, this child cannot stay with these parents. Do we really want to send them to foster care, or are there grandparents that can be brought into play? Are there other family members that can be brought in, all right? And getting those people hooked in, brought them into the plan, and training them to some degree, not fully, of course, at that state, but to help us bring down the crisis, okay? Any questions about that part of it? Okay. Yes, please.
As far as medication,
Yes.
Particularly when you would be addressing maybe different types of medications and trying different ones, what's the time frame for them to really take effect before you know
Okay.
that either they worked or they didn't?
It depends on the medication. All right, if we're talking about someone who's having a panic attack, usually a couple of hours. Okay. The anti-anxiety medications, and this is also why they're somewhat dangerous, act pretty immediately. All right, so if someone is having a panic attack, a Xanax, a Buspar, a Valium, we should see pretty quick results with that. However, that's also why those medications tend to be addictive, because they do give quick relief. All right, so if someone is not wanting to do anything but just pop a pill, it works. Okay, now the whole issue about how this gets going and so forth is something they prefer not to deal with. They can get hooked into those drugs, so we prefer not to go that way generally. All righty. Actually, in those situations, you actually would prefer to go environmental. Is there something that can be done here that can get the person calmed down environmentally? However, if we're having heart palpitations and really strong physiological reactions, that might be an opportunity to use those. All right. Antidepressants, it depends on the person and it depends on the medication. All right. We generally like to say we like to give them 6 weeks to see if we have the full effect of the antidepressant. And again, there are some medications, Zoloft, for example, which is an antidepressant, which right now we're using it mostly for PMS, would you believe? Because the half-life is short. You get it in very quickly and it comes out of the system very quickly. So someone is having severe PMS, gynecologists at this point will prescribe a dose of, as needed dosage of Zoloft just for that period of time because it's in and out of the body very quickly. Other medications, let's say Lexapro, for example, or Cymbalta, or let's say Wellbutrin, right, which has a different mechanism. We'd like to look at it about 2 weeks, see if we're getting any improvement, and try to hold on for 6 weeks and see if we've gotten maximum improvement at that point. Has it become clinically useful? Okay, does that answer that question? Okay, great. All right, so once we've got them stabilized, the next thing we need to do is to make sure that situation continues. And relapse prevention is really an educative process, all right? One of the things that I was very pleased about being able to bring about was something we used to call the wellness groups, which anybody who was on medication would be invited in to go through a series of 4 to 6 weeks in which we taught individuals about the medications. What are the side effects that you want to be really careful about? What side effects don't worry about? These will pass, all right? Stomach upset, things of that sort. When is the medication really not doing the trick for you? We want the clients to be knowledgeable about what they're taking. We also want to provide information on how to keep the relapse going. What are they doing nutritionally? All right. What are they doing exercise-wise? All right. What is going on in terms of support systems? All right. That may be one part of the relapse prevention, that type of education. Another part of relapse prevention, all right, might actually be what we call case management, all right, connecting them with organizations, with supports, all right, that don't leave them in that vulnerable position that they were in before, all right. In terms of, I know some of you probably worked with the LINKS program, which was early intervention for mothers, all right, mothers who are overwhelmed, postpartum mothers, people who were likely to not have the wherewithal to deal with young babies. A lot of education, in-home education and things of that sort that would be going on there. And the notion there would be basically to see if we can kind of keep the system at a level that the stresses are brought down for people. Along with that, we move into the third goal of mental health treatment, which is community integration. Okay? Now, this could go in many, many directions. It links up with case management, again, to other agencies, but it might go further than that. We may take a look at a person's vocational condition. We may take a look at a person's educational condition. We might refer them to social services for food stamps, for things of that sort. All right, we get down to the nitty-gritty of helping this person's environment, life, be one which kind of keeps them afloat. Now, the last goal of treatment, which is really the hardest, and I used to think that, well, everybody who came in for mental health treatment wanted therapy. Folks, 13% of the people who walked through our doors were really therapy candidates. Does that surprise anybody? Okay. Because when you're really talking about therapy, all right, you are talking about change. You're talking about change in the individual. Okay? A lot of people are very relieved when we can stabilize their crisis. They're very relieved when we can hook them up with agencies that, or other people or churches or whatever it is that will help them expand their support system. They don't even mind learning about medications and things of that sort. But when we get to where, as we say, the rubber hits the road, and we're talking about you're contributing to this issue. I'm going to say you caused it, all right? But there are behaviors, there are thoughts, there are interactions that are really not adaptive. And I like to use the word adaptive and maladaptive. I don't like to use the word pathological or ill, because that really kind of turns people off. And the really issue is to engage people to say, this is under my control. If there is something that I could do differently, then maybe the situation, would be very different. When you're talking about therapy, you're asking a person to do really 5 things. First of all, to kind of review what the bad situations have been and to start identifying what their contribution is, what their collusion is, what their behavior is, all right, that permits this to go on, okay? You're asking them to take a look at some history, their own personal history, and rather than come up with justifications of why they acted a certain way, I frankly don't care what those justifications were, all right? My concern is, was that way effective? Did it help you out of the situation, all right? Or was it simply a reaction. All right. I'm not the best artist in the world, so if you bear with me for a second, I want to show you something. Anybody here ever taken any courses in neurobiology? Brain? Okay, well, let's do it real quick then. All right. Believe it or not, this is a head. Okay? Usually, when people think about the brain, we hear a lot about right hemisphere, left hemisphere, don't we? Okay. We're going to do something a little bit different today. I'm going to talk about the caveman, and the CEO. Okay. What does the caveman do? They try to survive. Okay? This part of the brain, which is really a small part of the brain, all right, is called the limbic part of the brain. This part of the brain can only do 3 things. All right? This part of the brain can flee, it can fight, or it can freeze. Here comes saber-tooth tiger. Okay? Here's a little caveman or cavewoman walking down the street, or whatever, the road, whatever it is, and they see saber-tooth tiger coming along. Okay, heart starts to race. Danger, danger, danger. Well, there's a rock there. I could pick up the rock and throw it at the saber-tooth tiger. I can try to hide behind the rock, all right? Or I can freeze and play dead and maybe he won't be interested in me, okay? Reactions. Now, in this state, caveman is simply interested in surviving and they have tunnel vision. They don't see that the rest of their tribe is just around the bend. They don't think, hey, if I yell, they'll come over here. They don't see that there's a cave on the other side there that they could go to and maybe wait till saber-tooth tiger goes away. It's immediate, it's reactive. Okay? Anybody ever take Latin in here? Ah, good. Okay. What does the word agire mean? You remember that? To act. All right? Agire is the base Latin word, the root for act. In this word, re is a prefix, all right? It means to act over and over and over and over and over again. You do the same old thing, regardless of the outcome, okay? This part of the brain is an infant's brain, all right? This is when, when we see little babies and they have the soft spot, all right? It's because this is the only part of the brain that they come fully equipped with, okay? This part of the brain, the cerebral cortex, are you ready for this one? Is not fully developed until a person is at least 30 years of age. Okay, so when we talk about teenagers not being in their right mind, fully equipped, out of their minds, all right? They're generally trying to move out of this area over to this area. Okay? This part of the brain, I like to call the CEO, because this part of the brain is the part of the brain that analyzes,